So I'm going to be talking to you about response assessment and response criteria using PET imaging. And I'll focus a little bit on some of the commonly used schema for response assessment, both qualitative and quantitative. I'll give a little bit of a caveat at the beginning that in clinical practice, I'm clearly a qualitative person. So I want to convey, what's happening to the patient, and I'll use descriptive terms. And, when necessary, you can call the clinician and talk to them. Frequently, they'll call and say, I read your report, but do you think the tumor is getting better? Is it worse? They need to decide what to do with their patients. But there are some schema out there, and particularly for clinical trials, as we validate new drugs and look at new therapies, there are some regimented ways of doing response assessment as well. And so I will address some of those and show you a little bit of data that goes along with that. So what is response assessment? Well, response assessment is the ability to predict long-term treatment outcome. We don't just want to know what's happening to the patient today as we see them in the clinic. We want to use that information to hopefully predict what's going to happen to them down the road. And the shorter that interval of time can be, really the more ideal for the patient. You'd like to be able to decide within a fairly short period of time whether a particular intervention, a course of therapy, is going to be effective down the road. And if it is, you can continue on that therapy. If it's not going to be effective and you can demonstrate that very early on, you could switch them to another therapy before wasting weeks to months on something that ultimately may prove to be ineffective. So the concept that we're trying to aim for is really for PET as a biomarker, using it like we do other sorts of markers. We're used to seeing, histologic markers and serum markers in helping patients decide which therapy to get. Well, imaging can also be a biomarker in a sense. Being a way to interrogate the biology of a particular tumor, helping us to decide what the best course of therapy will be. In order for this to be of uniform prognostic value, there are just some things we need to keep in mind. Some of these are achievable with PET imaging. Some of them may be a little bit more difficult. Ideally, we should have a consistent application of our method, consistent criteria for scan interpretation, and uniform performance of the scans, which is always a little bit of a challenge. Those of you who read for various sites have the experience that when it's done on the scanner over here, the images look different than the scanner over here. SUVs are a little bit different, and that's why it gets hard to get to that level of precision where we're overemphasizing the numerical values, and that kind of brings me back again to the qualitative assessment. At the end of the day, we need to be able to look through those images and look through the variability in order to be able to make our judgment. But as much as we can control these factors, the better in terms of uniformity of that response assessment. I'm going to use lymphoma for the majority of the case examples just because I think the field of response assessment is the most mature. For lymphoma, we've been using it for several decades now, FDG PET imaging, to evaluate patients with lymphoma and to look at the response assessment. And lymphoma is a nice one because many lymphomas do respond quite well, and when they respond fairly dramatically. Some don't respond, and when they don't respond, that's usually pretty obvious as well. So it kind of avoids things in the middle ground. You look at tumors like head and neck cancer and pancreatic cancer, and I think there's a lot more uncertainty just in terms of the tumor biology than we tend to have with lymphoma. So I'll go back in history a little bit and talk about the Chesson criteria, which is a little bit based on and similar to what we use for qualitative response assessment, just looking at the degree of activity and using that as a judge. I'll talk about the PERSIST criteria, which have evolved over time, become a little bit more simple in their application, but I'll show you some examples of the PERSIST criteria. And then I'll spend most of the time in what I use in clinical practice around the Deauville criteria, which have now led into the kind of Lugano response criteria for lymphoma. And that's something that I think many oncologists are used to applying these days. And I'd be interested to hear whether you find that in your clinical practice that you're getting requested to give them a numerical value. I certainly am. And then I'll finish talking about volumetric measures, which I think is an area that's interesting and exciting, but maybe still has yet to find its